For your invitation, Mr. Chairman and dear colleague. I have the chance to share with you some of my experience with a very old problem. This is a first statement that is quite optimistic. Medical errors are largely a problem of the system and the atmosphere surrounding healthcare, and not an allocation of blame to individual physicians. Well, when we have to speak about this topic, we have a problem of semantics. And the first problem is the difference between a risk and a danger. The difference is very subtle. The risk is when you purposely do something that will put you in danger but could produce a greater outcome, sometimes positive. Danger is a situation in which there could be a risk that you don't want to take. In other words, life and surgery are risky. The patient and his surgeon or her surgeon are in danger. But let's put some figure on the risk for surgeon. Here, the figures are less optimistic. Recent paper in the New England Journal of Medicine 2011 from Harvard Medical School and the Harvard School of Government. The specialties are divided in the high-risk specialties and the low-risk specialties. For instance, general surgery at the top, dermatology at the bottom. If we look at the cumulative career malpractice risk, at the age of 45, 36% of the dermatologists have faced malpractice problem, 88% of the general surgeon. And we go up to 65, which is my age, we raised from 75 to 99%. So general surgery is really a dangerous job. Error and mistake. What's an error? What's a mistake? Well, I will take a quite Jesuitic stand by saying that an error becomes a mistake when one has decided not to correct it. When we occupy a position of responsibility, we are not only responsible for what we made, but also for what we have let happen. Which means that the operating theater, the personnel of the operating theater, is some kind of moral community. What is discipline? That's a question immediately related to the previous one. Well, when this question was asked to General Shoemaker, 3-star general of the US Marine Corps, during a Senate hearing in Washington in May 2004 about the US Army personnel misconduct in Iraq, he gave a very clear, a very honest, and I think a very nice definition. It is doing what is right when nobody is watching. Well, this is some kind of basic discipline in the operating theater that has been introduced by the World Health Organization in 2009 in the operating room. Discipline cannot decrease while complexity is increasing in the environment of the operating theater. We all know that technology are evolving rapidly, but complexity too. Actually, the concept of the checklist is not a new concept. It's even a very old one, because the checklist is intended to increase basic discipline and decrease error in order to avoid them becoming mistake. So mistake, error, discipline. The two fundamental reasons for failure are ignorance, error that are made due to the lack of knowledge, but also ineptitude, failing to apply what is already known because of incompetence, stress, fatigue, memory problem, burnout, disruptive behavior. Those are the reasons why checklists are so essential, particularly for the surgical profession. In addition, checklists could be good too in order to cool down the arrogance of certain operating theater actors. I said already that checklist it's nothing really news. To date, 1935. The B-17 from Boeing was the first aircraft to get a checklist. This came about when on his second flight in 1935, the aircraft crashed shortly after takeoff. During a major think tank session in Boeing, it was determined that the pilot needed a checklist. Flying this new plane was too complicated to be left to the memory of any person, however expert. And a journalist of the New York Herald Tribune even wrote that it was too much of a plane to be piloted only by one man or two men. Now, we are 40 years later, 1977. Captain Van Santen, a Dutch aircraft captain and flight instructor, captain of the KLM Boeing 747, was responsible of the terrible Tenerife airport disaster on March 77, the KLM crash with a 747 from Pan Am. That was the deadliest accident in aviation history. As a consequence of this terrible accident, sweeping changes were made to international airline regulation. Cockpit procedure, including the checklists, were also changed and reviewed. Hierarchical relations among crew members were played down. More emphasis was placed on team decision-making, and that was the beginning of crew resource management concept. Actually, Captain Van Zanten had a fantastic ego, but since 1977, there is no room left for the ego in the flight deck. Let's continue with this aeronautic metaphor in surgery and the increase of complexity. Well, Blériot, who crossed the channel for the first time in 1909, was not entitled to commit any mistake for one simple reason: he could not swim. Technology have evolved, complexity too. Here it's the instrument panel of different aircraft. I'm sorry I don't have the instrument panel of Blériot, but this is the panel of a B-17. Make no mistake, the sophisticated tool in the cockpit or in the operating room are no substitute for the skill of the team. And this is the operating room in my hospital in 44. What has left in my hospital is just the anatomy that has not changed between 44 and 2015. So some practical example: 13,000 different disease, syndrome, and type of injury, which means 13,000 different ways that the human body can fail. Clinicians have at their disposal some 6,000 different drugs, 4,000 medical and surgical procedures. Over the course of 1 year, a clinician will evaluate an average of 250 different primary disease and conditions, deal with more than 900 active medical problems, prescribe some 300 different medications. And in the ICU, every 24 hours, the average patient requires 180 individual actions per day. The nurse and the doctor were observed to make an error in just 1%, but that means an average of 2 errors per patient every day. So as far as safety is concerned, can we learn something from the aviation industry? Well, the answer is probably for any surgeon, yes, but. Yes, but because we as surgeons believe our job are too complicated to reduce to a checklist. Sick people, for instance, are phenomenally more various than airplanes. Mapping out the proper step for every patient is not possible, and the surgeon remains skeptical that a piece of paper with a bunch of little boxes to click would improve matters. Well, checklist might help, at least in some corners. What, for instance, are the vital sign flow sheets that are in use in any surgical ward, if not some kind of checklist? Let's see what we can read in the November issue 2010 of the Bulletin of the American College. that was quoting very widely "To Err is Human," this book from the Institute of Medicine, published in 1999, we can read that 98,000 patients die annually as a result of medical error in the United States hospital. This level of fatalities is equivalent to 2-3 jumbo jet crashing every week. And in 2007-2008, 1.5 billion commercial passengers flew safely with no one single airline fatalities in the United States. Over the last couple of years, the results were not so good. So, as far as safety is concerned, can we learn something from the aviation industry? The yes, but is now a clear yes. And I had the experience to work with some young pilot in a small society as a scientific advisor, just voluntary, and they used me as a surgical old guinea pigs. They put me in the safety. In the flight simulator, I had the chance to take off and to land an Airbus 330. That was a very interesting experience. After a briefing, I would put on command. I had some problem at the takeoff with the flaps and the landing gear. During the flight, I appreciate the teamwork, which means never having to take all the blame on yourself and not put the blame on other people, which is not always true in the hospital. No place left for my ego. Vocal repetition of checklist item at certain point during the flight. Stress situation. Suddenly I was in an auditory exclusion and a tunnel vision because I was so stressed. Here you can see my hand is completely stitched to the throttle of the airplane, and the co-pilot had to take my hand off because I couldn't hear or see anything else. Before landing, again, I was okay with the flap. I was just positioning the plane in the direction of the runway, so I was quite busy. My approach of the runway was excellent, but I forgot to take out the landing gear. So, debriefing was a lesson of modesty and humility. I learned a lot about cockpit or crew resource management. I understood Ted Turner's sentence, "If I only had a little humidity, I would be perfect." So the correction of error is more effective if one can prevent them, thanks to the use of a checklist. But the checklist must be well adapted to the local environment and consensus-based for the local team. The checklist must not become a coercive measure, but an incentive measure. And one very practical example of incentive measure consensus-based is the recommendation and the statement from the ACS on the use of cell phone in the operating room. Well adapted to the local environment, I said. Well, what's the local environment of the operating room? The operative theater is a complex system, not only because we are dealing with surgical patients in bad condition, but also because they are objective factor. The sophistication of the instrumentation, the volume of information to be dealt with, the nature of communication and coordination of the member of the team, the emergency context, the uncertainty context in which decisions have to be made and operation carried out, but also subjective factor, workload, fatigue, burnout, permanent adaptation to new technologies, continuing education and training, pressure for profitability. Just to remind you that clinical efficiency is different from economical efficiency. Needless interference in the sanctuary that the operating theater should remain anyway, too many phone calls, too many messages, too many useless and futile talking and noise. We have to learn what team performance is all about, which will decrease the number of errors and increase discipline in the functioning. And that leads us to the different type of error that we are making, active and latent error. An error is active as long as it occurs directly at the level of the operator, easily identified as being the guilty. The effect of such an error are immediate. The work in an assembly line, the pilot in the cockpit, the surgeon operating the wrong side, the anesthetist unable to intubate. But the error can also be latent, and it is latent as far as it is not related directly to the operator, because the links of the causal chain are not directly under the control of the operator. But in fact, the error is the result of bad installation, for instance, incorrect implementation, inappropriate maintenance, poor design of the system. Here, all the operating room are different. The latent error can be hidden behind routine procedure, badly structured management and organization, erratic managerial decision, irrational political interference, arrogance of decision makers, unrealistic budgetary imperative. And all of this can lead the actor of the operating theater to work side by side with sources of error, or even worse, to tolerate them. The active error can be rooted also in latent error, because fatigue in the operating theater personnel can be rooted in bad work schedule, in bad rules. Just to remind you that the Bhopal tragedy, the 3 Mile Island accident, the Chernobyl accident, the active error happened at night, but there was a series of latent error behind. Sleep deprivation after 24 hours is equivalent to the blood alcohol content of 0.10%, which is above the legal tolerance, at least in my country. Well, in Chernobyl, probably they push a bit too much on the vodka too. The source of latent error is invisible, because what belongs to the daily environment becomes invisible. Here, a crazy guy put fire to his bed in my surgical ward. Everything went fine. It was during the night. And when we did a debriefing on the next day, actually during the night, nobody could find the extinguisher. The extinguisher is stuck on the wall in front of the nursing station. So everybody is crossing the extinguisher 100 times every day. But nobody could realize in an emergency situation where was the extinguisher. When I was telling the story in the operating room the next day, my scrub nurse was telling me, well, where is the extinguisher in the operating theater? Well, actually, it's here in front of the roster for the on-call of the nurse. It's several times the same nail in order to avoid error born to routine. So 3 models quickly on error. The human shell model, which is a variety of contextual and task-related factors interacting with the human operator in the middle, the individual actor. The human factor is rarely, if ever, the sole cause of an accident. As a result, the shell model considers always both active and latent failure. And the life-where interface involves the individual actor with all the other actors working in the operating room. That has led the aviation industry to design the CRM in an attempt to reduce error at the interface between professionals. It's exactly what happened during cardiac surgery. You have 4 teams that have to communicate and to work together. And communication is not always the best, as you can see on these slides. The Swiss model, everybody knows now the Swiss model, because the defense against failure are modeled as a series of barriers represented by a slice of Swiss cheese. The hole in the slice represent the weaknesses in individual part of the system and are continually varying in size and position across the slice. The system produces failure when a hole in each slice momentarily align, permitting a trajectory of accident opportunity, so that a hazard passes through all the holes in all the slices, leading to a failure. And the last things is the Henrich model, which is a model based on the domino theory. The causal factor fall like domino, one root cause trigger another, and then another, until an accident happens. Removing a causal factor can prevent a chain of reaction. But which is the first domino and who decide? You see that the problem is still open. And for one major injury, 29 minor injury, and 300 near miss. That's the real question we have to face, because the vast majority of these 300 near miss are not reported. Thank you very much.
Thank you very much, Prof. Any questions?
Thank you very much for the excellent lecture. It's a small comment. I used to work in the UK for a long time, and we have the European Working Time Directives. When I come to this part of the world and I started to work, the contracts we have states clearly that, yes, you're working 48 hours per week, but if the work necessitates your presence, you have to be there for unlimited. It didn't actually specify that, how many hours. In the UK, if you are called at night or even interrupted your sleep after 11 p.m. till 7 in the morning, enough interruption, then your next day should be off for the sake of the patient. I don't know, we are here, a group of practitioners from different hospitals. Why don't we unite together and try to raise the concern that, as you said clearly, which is a known fact, that fatigue can make accidents happen?
Well, thank you for your comment, but actually in Belgium it's the same. And maybe you don't know, but there is a EU regulation now, limiting the number of hours that anybody can work. Now, the other problem is that when you limit the time of work, you increase also the number of handoff. And a lot of problems happen during the handoff, including in the operating room. So we are somewhere between a progress and a regression. It needs to be analyzed at the European level.